Thanks. It's a very special day for me. I did my training in Michigan and fellowship, and I worked at the internet so in as a attendant University of Michigan. And also Dr. Minoshima spent 10 years in University of Michigan. It's core part of my life. And also we spent earlier stage of our career in University of Michigan. So another so we have the chair of the Department of Radiology, University of Michigan, Dr. Vikas Gulani, is as a special grant round speaker today. And I'm going to just read his bio, send it to me. Dr. Vikas Gulani is a professor and chair of the Department of Radiology, University of Michigan, and also co-director of the Michigan Institute of Imaging Technology and Translation. And here's an interesting, very important part. He's committed to collaborative, diverse, and a friendly work environment where people are valued above all else. And yet clinical research and teaching and excellence is expected. And most of people send a bio say, well, you know, I graduated from this and this and this, and I had this grant, how many peer review publications. But he put that in the very second sentence. And that will let that sink in. That's very important to him. So he trained in a chemical engineering, at UCLA, and then he did a PhD work at the University of Illinois, Urbana-Champaign, and his residence and fellowship training at the University of Michigan. And then he also completed a postdoctoral year in physics at the University of Oxford in Germany. So his research interest is very broad, but it's really heavy MR research, and including quantitative MRI, fast MRI, MRI guided intervention, accessible MRI, and abdominal MRI, and prostate and liver imaging. So he'll be speaking because of his broad knowledge and experience. We had a hard time to narrow down to what he can talk. But we added MR fingerprinting and MR guided biopsy, prostate MR as an example. So here's Thank
you. So thank you so much for having me. I was very kind and really it's an honor to be here. And I want to start by thanking all of you for taking the time to listen to what I have to say. We get research support from Siemens that applies to the fingerprinting work and the low field work that you'll see, intellectual property that has been licensed by Siemens and Philips, mostly the fingerprinting work. And then the research support we also get from Biomedical for the MR-guided intervention. Okay, so if we think about what our goals are in radiological imaging, the core is the diagnosis, follow-up, treatment of disease using this. But another core principle is minimal invasiveness as a principle. It's a core of what we try to do. In this context, I like to say that every biopsy is an infant belly. Every time we have to go and find tissue, subsample little bits of it, look at it under the microscope, subsample even what we're looking at under the microscope, failing as imaging. And so this is a problem. And this is what it looks like. So this was, one of my early biopsies as an attending, and probably the most difficult one that I've ever done. We were sliding behind the aorta, and I was very proud of what we had done. Armpits, very excited. Think about this. He's scared out of his mind, right? And for good reason. And so this is not a good state of the state if we are to get to a future that doesn't look like this. And we fail often in the case of prostate, even worse. This is what's happening to a man's prostate on a routine basis right now. And it remains the only organ we tackle systematically for cancer without the human area. Is that okay? Not with my prostate. So, it's an open problem. So we fail far too often. And we are not exactly certain about what we're saying when we're dictating. And so the old, people make fun of radiologists, but I think there is some truth behind that joking. So, a long time ago, I started to ask myself this question, like how many cells exist in a centimeter cube of tube? It's relatively a small tube that we might have. And you can argue between 10 to the 8th and 10 to the 9th, that's a boatload of cells in a 10 to, 1 centimeter cube of tube. And if you start there, and then you go down to a half a centimeter or 1 millimeter mass, you still get to 20 doublings of a tumor before we could detect it. And then 1 millimeter cube of tumor, we have a very hard time detecting with any technology that's even around the horizon today. So my attestation to you, my thought to you is that resolution is not enough when we're looking at characterization of tissue, and detection is one thing which resolution is needed for, and characterization is another question that we're dealing with. And so if we look at our goals for diagnostic imaging, we want some definitive diagnoses. We want to be able to personalize the monitoring and tailoring of treatment. So in order to do this, I would argue that we need numbers. We need to be definitive. We can't do that with just a qualitative description of the tumor alone. So this was a parking lot very close to where I used to work, which I love this picture because I'm an MRI nerd. But protons are also known as spins in our world. And my PhD advisor said, if you tickle the spins just right, you can get them to do just about anything. What is that just about anything? There are all these properties that MRI is sensitive to. Right? And so we can, in some way or another, interrogate all these properties. We measure. Measure this. And I would say that we occasionally measure Hounsfield units and flow in ultrasound, but really this is what we're left with, right? And even that, so Roy Philly, who was a very famous radiologist, is supposed to have said, a radiologist with a ruler is a radiologist in trouble. And so we have a lot of resistance, I think, to being quantitative in what we do on a day-to-day basis. My question is, why are numbers so darn hard to get in MRI that this is what the state of the state is today? Now, if you look at various properties that we look at with MRI, there's multiple signal forms that you can try to model. Mostly they're an exponential decay and exponential recovery, or some sort of line that you're trying to fit. And so you say, okay, well, you deliver a tickle and then you look at various data points to map what you want to map, and you should be done. Well, this is great, except that each of those dots is an image. So that's an expensive experiment, 5 images or 10 images or whatever you might need. So let's say you want to measure T2. Well, you have 2 tissues that you want to sort of separate, and you have a series of images that you might get, and they might be differentially T2 weighted, and you fit a curve and you get your answer. But that's 5 times longer scan time. So this is a very difficult experiment. So what do we do instead? So we take one point that maximally separates out these 2 tissues, and we get a weighted image to try to maximally separate these tissues out. Right? That's our T1 weighted image or T2 weighted image that we're so used to within the clinical routine. But there are assumptions built into this model, and Graham Bitter, who's kind of a legend in MRI, pointed this out to me back in 2008 or 9, and then published a paper on it, that it assumes that there are only 2 tissues. As soon as you have 3 tissues, the concept of weighting starts to become really problematic. And you assume that one point can really separate them, and numbers between these 2 curves are not that important. So we use this, and T1 and T2 color just about every MR image that we have. So if there was a Hounsfield unit MR, would argue it would be T1 or T2 as a starting point. Now, here are two images, coronal T2-weighted images, and they're both T2-weighted, and obviously they're very different. And one is a single shot T2-weighted, single breath hold based or SSFSE or whatever you might want to call it. And then you have on the right an MRCP. And so some might say, oh, well, you're being a little, this is a comparison that's not really valid. Okay. What about this? This is vendor 1 and vendor 2, and I will not insult any vendor, but this was taken a week apart, these two images of the prostate, and the prostate didn't change in this group. And look at how different these two look. And there's a tumor in the yellow arrow. There is a normal appearing peripheral zone in the white area. That's a normal peripheral zone. Then there's another area in the transition zone that is concerning for tumor. Now, all of these are there, and they look very different in two different. This is PIRADS. We use PIRADS all the time. And Masoom Haider in Toronto sent me this slide, this paper, and look at the variability of the positive predictive value PIRADS across 26 MR centers. So we're proud of PIRADS. I'm here to say it kind of sucks. And so it's a real problem in our field. And in the meanwhile, we have a stated goal in all of medicine to want to move towards precision medicine. So can we get to better answers, and could we quantify our certainty or our uncertainty? This is my goal and what motivated this work. Now, from 2003, when I was a postdoc in physics at the University of Würzburg, through 2013, we had this naivete that we're just gonna, people have tried to solve this problem before many times in history of MR. We'll just do it better. We'll do it faster. So myself and Mark Griswold started working on this. And, I'm glad I was young, because if I'd known how hard the problem was, maybe I would have stopped at that time. But here we are. And, we published and we published and we published, but it wasn't working. So why? So consider a curve, an inversion recovery curve. And in this case, let's suppose it's sensitive to both T1 and T2. And we're really interested in that fast recovering part of the curve. And the flat part of the curve, we can sample that forever, but it's not telling us a whole lot about what's happening in this curve. So you collect all these data points. And so the flat part, you can keep collecting, but again, it's useless. So, okay, so why keep collecting there? Meanwhile, if your sampling density goes down a little bit, now if you're not really sampling accurately enough to really characterize that early part of the curve, which is going to give you the numerical answers that you're after. So not only are we slow, we're not very good at what we do. And this was the issue that we were running up against in doing all kinds of traditional mapping we were interested in. Right? So this was the breakthrough for MR fingerprinting. And I love this cartoon from the far side. It's time to face reality, my friends. We're not exactly rocket scientists. Well, someone built this rocket, and made it fly, kind of. So this contraption can fly. And I look at the fingerprinting work as kind of this contraption. So if this curve is not satisfactory, and this state of the state is not satisfactory, and we're not getting enough looks at the early part of the curve, and we're getting too many looks at the late part of the curve, could we live in a curve like this that's always fast evolving? And that was the central question that we started to ask ourselves. And but the question becomes, well, how do you model this? Because that's not an equation that I can write down. I mean, I guess I could try to write it down, but it would be very hard. So fitting it is hard. So how do we do this? So what we do is that we say, okay, well, there's a set of physical properties that we're interested in, T1 and T2, let's say. And they can vary over a range of numbers. And they have a realistic range, say 100 to 3,000 milliseconds in T1 and 10 to 500 milliseconds in T2. And then you have a sequence that you're playing at the scanner. And that scanner you can control. So you can say, well, I can vary the flip angles, or I can add preparation for T1 or a recovery time, something else that you might be able to do at the scanner. Okay, so you say, okay, for each combination of T1 and T2, let's say 110 you start with. If you played all of these sequence preps out, you simulate that sequence, and you get the first entry in that dictionary of the possible time course that sequence would have, that signal would have evolved. You do that then for 120, 130, and so on. And you keep doing this, and you build up a giant dictionary of all possible combination of these time courses. And then you collect sequences and these images, and these images are very undersampled. They are kind of really crappy looking images. And they're constantly varying spatially across your field of view. These images, no one in their right mind would use to try to diagnose anything. But what they're giving us is a signal time course in each pixel that is collected very, very fast, right? And so this signal time course then can be compared to the dictionary. You go through a pattern matching for each pixel, and that noisy signal matches to some signal that was in your dictionary that is not noisy, and it gives you the combination of T1, T2 that went to making that image. Now, this is the central way that fingerprinting is done. Let me illustrate it to you in this way. So let's say one time course looks like this, another time course looks like this, a third, and a fourth. So we're just going to go with 4 simple time courses, right? And they have T1s and T2s associated with them. Now, this is your image that you're trying to create. And in the first voxel, you get something that looks like a dark blue, right? And that matches into a light yellow and a dark and a light blue for T1 and T2 respectively, right? And then your second time course, and what does that correspond to? A darker pixel, and then a third and a fourth. So you're going voxel by voxel, you're matching the time course that fits that voxel, and that's mapping to T1s and T2s that went into constructing that dictionary entry. So if you keep doing that on and on and on through the whole image, you get a set of maps, and that set of maps actually looks pretty darn decent. I could go into details of how this is, but was the central breakthrough for us anyway, and how we do this mapping. We made a lot of philosophical decisions to get there. That is, that we're after numerical tissue characterization, and the entire experiment is designed around being quantitative. Those individual images that went into that time course sucked, and we were okay with it. But we want that time course to be very high information, because we want lots of looks at that fast evolving part of the curve. And we will tolerate low quality underlying images. So there's work I'm not showing, abdominal, cardiac, brain, high res, dealing with motion, multiple tissue properties. I'm trying to tell you a story from beginning to end on one organ, so you can see where this can go. So starting point. Anytime you do quantitative imaging, the performance has to be the same day to day, much more stringently than what we're used to on our scanners. Scanner cannot vary, site to site cannot vary, and who is to guarantee this? And so these variabilities in measurements come in, same day repeatability, 1 week reproducibility, intra-subject, which is getting to biological variability that you have, and inter-subject. And so, you have to have phantom measurements, and you have to have in vivo measurements. So this all has to be done, and so we started to do this work. I call this this is this phantom. I call it the Death Star. But it is, what we have to do. We have to have a standard set of measurements that we can use to kind of calibrate our measurements across scanners, and to be able to do this. Then you have to do this and repeatability, reproducibility work in each organ and with each sequence. This is not sexy work, but it is really critical that to do it in order to be able to draw any conclusions when we get to in vivo work. And so this has to be done. This is a little bit of trench warfare across all these organs as well. And then there are confounders. So again, I'm not getting into the detail of this, but we've studied what could confound these measurements and can we remove some of these confounders from our T1 and T2 measurements. But I'm gonna now switch gears and talk about like what are the clinical possibilities if you start doing this. How do we use these numbers that we're after? Okay, so consider a normal state, which is shown in blue, and then two disease states, which are shown in light green and dark green. And so on the first look, you say, well, there's a lot of overlap. There's some overlap between blue and light green. There's a lot of overlap between light green and dark green. But if you start to draw some cutoffs, those cutoffs, the first line being between blue and green. So below that, there may be some overlap too, but above it, there is normal tissue. And below the second line, there is definitely abnormal tissue. So these are the kinds of thought processes that you have to go through to use quantitative imaging in a proper way. It's, showing these error bars is something that we do in a paper, but in a reading room, you need actionable evidence. And this is really critical. So, and once more, I emphasize this has to be done for every single tissue at hand. So we're focusing on prostate. We started with a sequence that we developed that was not the initial fingerprinting sequence. The initial fingerprinting sequence was with balanced SSFD or TrueFISP or however else. But there are many variations of this that you might use. But this was with FISP, which is a form of a variant of a gradient. And then we started to write a series of papers looking at the peripheral zone of the prostate and the transition zone of the prostate and doing both untargeted and targeted validation against tissue. We wanted to answer a few clinical questions. Can we tell cancer from not cancer? Can we become better at looking at the TZ, which we're really bad at right now? And can we see which cancer is clinically significant and which is not? Which is the opposite question of what many people were asking at the time. So people are often asking what is an aggressive cancer, but most of prostate cancer is actually not aggressive. So I was interested in well, if I can spare the man who has non-aggressive cancer from a lot of aggressive treatment, I might make a bigger clinical impact. But that's it's a philosophical decision at the start of the project. And then can we aid with Pyrex-3 lesions? So this was one of the very early cases. And this project was led by a medical student. And she published in Radiology and started by looking at prostate cancer. And we included diffusion mapping because we know that diffusion is important in the prostate. So another point was that I was not wedded to just fingerprinting, but I was trying to bring in other pieces of information that I think might be relevant here. And we started to look at T2 versus ADC. And so the initial plots on the left, which was all comers and on the right were targeted. And these initial ones were targeted by a cognitive targeting. It's very early primitive work. But nevertheless, it started to give us a tantalizing possibility that those open circles, those low-grade cancer, were behaving differently than the dark circles, which is high-grade cancer, and which were all in turn different from the little plus signs, which are normal tissue, right? So we started to be able to say, oh, this has promise. That was the first paper. But then we said, okay, well, we want better targeting. And so we started to target these, and we started to target them with a combination of either fusion biopsy or in-bore biopsy. And I'll get into the story of in-bore biopsy a little bit more in the future, but we, this is what we started to do. So we would have T2 weighted imaging and ADC mapping, which were used to identify a lesion. We would get T1, T2, ADC, characterize that. We would validate it in some form of tissue diagnosis. And what we saw was that not only could we tell cancer and not cancer apart, but intermediate and high-grade cancer, and intermediate in this case is defined as grade group 2 or Gleason 3 plus 4 equals 7, right? So grade group 2 or higher cancer versus low-grade cancer, which is grade group 1 or 3 plus 3 equals 6. And with very high probability, with very high AUC, we were able to separate low grade from intermediate and high grade. This is very interesting to us. And so if you look at targeted biopsies in the peripheral zone, this is a bit of a busy plot. But if you look at this quadrant in the top right, theoretically, if we can carry this work to further completion, validation of multiple sites, people in this box on the right could be spared biopsy. And if every biopsy is an imaging failure, this is a start towards where I want you to go. Now, transition zone is a whole other area of the prostate that we have very poor understanding of. And so could we tell normal transition zone versus prostate cancer in a lesion of suspicion? The answer is yes. And T2 and ADC give the best AUC of practically 0.99. But what about prostate cancers versus non-cancers, i.e. in a lesion itself? And here's where a surprising finding came in. Actually, T1 and ADC are more useful than T2 and ADC. So a little bit of a surprise there. I wasn't surprised that T2 was less useful because we know, I mean, we look at transition zone, there's a lot of confounding low T2 signals all over the transition zone. But I was surprised at T1. And my hypothesis is that T1 weighted images don't sufficiently separate, at least the ones we obtain, don't sufficiently separate the tissues. They look like blobs. But when you start to measure this stuff, you start to be able to look at these numerical differences. All right. And in the transition zone, then you start to be able to say, well, can we use ADC? And depending on how sensitive and specific you want to be, you might be able to separate cancers from not cancer. And so this is, again, a very tantalizing possibility. And we were starting to get hints that perhaps IRS3 lesions could be separated into high grade or high risk and low risk lesions. That would be another really great contribution if we could get to it to the future. Okay, so where are we going with this work now? Well, the original work was at 1x1x5. It's hard to correlate that against the high resolution T2 weighted imaging that we do, or even the diffusion weighted imaging. So we want to do 3D fingerprinting at 3T. So these are, this is a benign lesion that we imaged in a patient, and here's a 1x1x1, so isotropic in 3 dimensions, in about 8.5 minutes. But I think the future probably more realistically 1x1x3 for at 3T for in less than 3 minutes, because this could be incorporated very easily into clinical routine. And the 1x1x3 is not zero field. So all the images that you get on the scanner are kind of interpolated, let's just say. And this is not interpolated. So we could really match scanner resolutions with this. And so we're starting to analyze these data for cancer and grade, just like the work that I have shown you. Not sharing it because it's a little bit repetitive, but it's going down that same direction now at a higher resolution. We are also starting to do 3D MR fingerprinting at 0.55T. And so these are initial results. This is longer. We're dealing with much lower SNR at 0.55T, but you guys are getting a 0.55T, so I'm sharing these data. And so this becomes an interesting possibility. Now, one thing that's not lost on anyone who's doing quantitative T1, T2 mapping is that if you have the quantitative T1s and T2s, could you reconstruct weighted images from your collected maps? The answer is yes. And they need to be then matched up against clinical images. And while we're doing this as a computed image, this could also easily be done by an AI approach, which probably would be more effective. So this is something we're thinking about and going to be working on. It's sort of manpower limited and how many different things we can do with this at the same time. And we're starting to separate, normal transition zone and characterize normal peripheral zone and normal transition zones, because T1s and T2s are field dependent. So we need to do all that numerical work as well. Okay. Another holy grail in all of imaging is response to treatment. Prostate, not a great target directly for that. Most of the time, it either comes out or it gets radiated so much that the entire gland changes. But we are exploring this in metastatic prostate cancer with Dalmuco at Royal Harvard Hospital. An initial paper been published, and we're looking at a second and third paper and starting to look at where we want to go with this response to treatment. We've thought about response to treatment in breast imaging and in other areas as well. Okay, can we improve our dimensionality? So we have T1, T2, fusion, perfusion, fat water, oxygenation, all these things that come in from MR, right? And so these are all possible with a quantitative approach to imaging, and you could modify a fingerprinting exam to measure some of these properties. But what about non-MR properties? And this was a subject of discussion just before I came into this room. So, you know, PET brings in much data, CT, molecular imaging, genetic markers, proteomics, urine markers, and on and on and on. So really it is possible to bring in quantitative streams from multiple directions. And I think that needs to be done into the future. And hope some of you will be inventing that stuff as we go along into tomorrow's radiology. Lots of outstanding issues in the prostate MRF. You know, some of them are like pretty obvious, but we need to do this at more than one site, and resolution, speed, you know, further correlation with the Radin path, you know, and on and on and on. Which just goes to say, when you open one door, you run into a dark space in another place, and you need to keep digging to figure this stuff out as we go along. Now, I mentioned to you that we started doing in-bore biopsies. This was a paper that came out of our in-bore biopsy story. And we were just, you know, when I started doing these in-bore biopsies, it started because I was getting discordant results. I was calling something cancer. I was getting back something that said not cancer. And I was like, how can it be? Like, I just know that it is cancer. And so challenged by my urologist to do the in-bore biopsies. So took up the challenge, started doing them. And then this became its own kind of clinical service. And so you'd find some lesion, it would be interesting on, say, ADC map and pre-biopsy T2-weighted imaging, and you might be doing fingerprinting on it or not, but you wanted to sample it because there was some discordant result, or it was a hard to reach lesion, or whatever the reason may be. And so it became its own service. We did about 175 of them before I left Western. And, you know, it just became a part of my life that I really enjoyed. So, you know, now we've taken this up at University of Michigan. We are a CON state, so using a 3T for this purpose is not on the cards. So I started saying, well, can I try to do this at 0.55T? And so this was the starting point. So, you know, the standard truss biopsy, there's lots of pitfalls, as we know. We tend to miss certain areas, or we may sample a part of the area, the lesion that that's not the most aggressive part of the lesion, or we may not reach some lesions because they're too far away from us, and so on. So MR-guided biopsy becomes very attractive in these scenarios. Consider this patient. This came to me. This was may have been my first patient at the University of Michigan. This patient, over a course of 5 years, had a rising PSA, had 3 MRIs. He had 4 biopsies. And the most aggressive biopsy showed grade group 1 cancer in 10% of his core. Meanwhile, his PSA was over 25, right? And so this was like, what is going on with this patient? Now, one issue was he had a hip implant. And so he was, you know, half the prostate was kind of grayed out on 3T imaging. And so we biopsied this, and when I put him in the scanner, the lesion that had been identified is the one that you see in the right peripheral zone. And so we sampled it, but that's not the one that was worrying me. In the same patient, when I put him in the scanner, I saw this thing in the anterior of the left peripheral zone / transition zone. And the hip implant, of course, at 0.55T, since every artifact known to women and men gets smaller at 3T at that point at the lower field, that we could see the prostate much better. And when I went back to the 1.5T images, he had a 1.5T scan before. I could, in retrospect, kind of make it out, right? So this lesion was uncovered, and actually I sampled it first. I mean, I showed you the other side first, but the punchline is I sampled it first because as an MR reader, this concerned me a lot more and made sense, fit with the story of multiple negative biopsies. So this turned out to be grade group 2 cancer, and this is clinically significant with a PSA of 25. This is something they'll want to treat. Right? So this person, then we have a change in management. A second part of this is that if you think about image-guided intervention, you want to try to biopsy with the modality used to diagnose the lesion. That's the most accurate way of doing it. Now, in prostate, we make a fusion choice because if we were to biopsy every prostate with MR, that's clinically unrealistic. But we can do it for problem-solving cases, right? So that was the original paper. And so why 0.55T? Because we have a large bore. It's 80 centimeters, pure metal artifacts. We saw that issue, and higher access, at least at our institution. And in complex scenarios, so we get a lot of patients who don't have a rectum. We get people who have IBD or cancer in their rectum. We have discordant imaging, and we have difficult to reach lesions. All of these are reasons to try to do this. And we had the prior experience, and we had done this work before. So step one in doing something like this is determine if it's even clinically feasible. Now you saw that, I mean, yes, you're gonna see that it's clinically feasible. Otherwise, I wouldn't be telling you the story. But we did need to know if we can see the needle adequately, the lesion adequately. Can we target it? Can we optimize two approaches, transrectal and percutaneous? So we have published an initial paper on this, and we considered three approaches: transrectal, transgluteal, and transperineal. So the transperineal is advocated by some because it does not require antibiotics, but it's very long. I went and observed it. It's 2 or 3 hours, and it requires anesthesia support, which I didn't want to incorporate into my process. And transrectal is advocated against by some, but if you look at it, you can also do it even without sedation. Most of the people getting transrectal biopsies in the urologist's office do not have sedation. But it does require antibiotic prophylaxis, which some people do not like, but it's very familiar to urologists. In the middle is this transgluteal percutaneous approach, which you can do with moderate sedation and does not require antibiotics. It's familiar to radiologists. Anyone who's done a CT-guided biopsy should be able to envision an MR-guided transgluteal approach. But systematic sampling with this is hard, right? So these are the issues. The transperineal, to me, just the requirement for anesthesia is such a nightmare that I just said, this is not what I want to do. 2 or 3 hours for a biopsy, I don't want to do this. So some will argue against this, particularly certain groups around the country that have developed this, and I have no problem with them doing it, but it's not for me, right? So, but this is our approach, and this has taken center stage for us. So here's how we do it. We have a Soteria robot. We do transrectal, and we have 2 coils that we place, and we do kind of a CT-guided approach, but with MR, using the percutaneous approach, right? So what have we learned? So far, actually, our positive, we've done about, the papers on 17 patients, I think, or so. We've done 23, 24 patients, and we have a very high positivity rate, even higher than what we had at Case. At Case, my positivity rate was 63, 64%, but we have over 80% yield. And this may be because we're getting patient selection from our urologist that is high-risk patients. I don't know, but nevertheless, that level of accuracy, that level of positivity means that we're accurately targeting. We cannot be, we are not missing the lesion. Procedure time is still too long at 75 minutes. Some of it will come down with experience, and actually the last few we've done in less than 60 minutes, but I want it to be 30 minutes in and out. So that's my target. And so we need to figure out how to get there. And so that gives me plenty of opportunity to try to innovate. We have a large board, gives us space to work. So this is the percutaneous approach, and you can see this lesion that we're interested. I have never seen before this particular biopsy 100% of a core being positive. So here we are. And so this was targeted. We have targeted very small lesions. This is a 7 millimeter lesion. I don't know if you can see my arrow. See it? So that was the lesion that we targeted. That came back positive for cancer. Now some of this can get very tricky. This was a lesion we were targeting, and so here is a rectal cancer. So that's marked with C. Here is an obturatus internus muscle we don't want to hit. That could cause real problems. And you had to slide between them. So I'd put him down on his side to get the cancer to fall away and then slide in. But this is the kind of thinking we do all the time with CT-guided intervention. Why wouldn't we think about it with MR-guided intervention, right? So, but you can do fairly tricky procedures. Okay. So what's next? We need to get faster. We need real-time guidance, which Siemens is developing. I'm a little nervous about some of it because the slice thickness is high, thick. And, you know, as I'm targeting, if I'm moving around a little bit, it makes me nervous. So this is not one that I moved to yet, although it's on my mind. And I intend to take, when I get a chance, a weekend to play with a piece of meat, get really good at it before I try it on anything more serious, right? So get really, really good at targeting it every single time before moving to something that there's a high penalty for a patient. And then, but if I can do it, then it'll be much better for the patient because they can be in and out in a half hour instead of repeated imaging. We need some real-time guidance. We need optimization of lesion conspicuity. I have needed every bit of my experience reading 3T prostate MR to be able to correlate 0.55T because these lesions do not look the same and they're not as conspicuous. And so it requires a knowledge of what you're doing. And if this is to be generalized out there, you can't have it be that specialized. So, you know, optimization, personalized contrast, I think is going to be important so that it helps us target. We need to be able to have better sequence selections. I would love to have coils with holes in them so that we don't have to jerry-rig our coils this way. We need some specially designed hardware. The biopsy, the introducer needles that we're using a 1618 system. It's not, first of all, it's not fit well together. So I have to use my knowledge of how long the needles are to use the biopsy gun. But secondly, it's I find the metal is a little too soft. So we're working with Cuff to help design new biopsy equipment. And then we need to move to ablations. If you can target it with a needle, you should be able to ablate it with other needles. So, you know, this is the next step. So some of it now ties back to the MRF-driven design. So look at, for example, individualized contrast. So this is an example. You take a T1, T2 ADC map, and can you design an optimized contrast that's not T1 weighted, it's not T2 weighted, it's not diffusion weighted, it's some weird mix of all three, but it makes the lesion conspicuous. And it ought to be possible to design such an experiment. This is all theoretical right now, but this is where we would love to go. So now I want to end by saying that this is my message to all of you, especially the younger people in the crowd, that, you know, there's a lot of stuff in radiology that's not well understood. And it's hard, but if it was easy, anyone would do it. But if it's hard, it's maybe worth doing and it's worth pursuing, and it'll keep you interested. I have a whole separate talk which I could share with you on how most of what I did was a failure. Right? And you saw, got a glimpse of it. Like we struggled around for 10 years, publishing papers that didn't answer. They were good papers, but they didn't answer the question. Right. But they were moving us closer and closer. Fingerprinting, to people who haven't done it, looks like magic. It's not magic at all. It's 10 years of work. It was a series of steps towards the right direction. Right? And so if you put those dots together, most of it is failure, but these problems are really worth, they keep you interested in our field. I have a lot of great collaborators, both within and outside the University of Michigan, and the team at MIT is outstanding. That I thank you, and I'll take questions.
Thank you so much. Really wonderful, very broad topics, but now prostate is not my area of expertise. So you may have questions or comments. Anybody has a question? Anybody?
I have a question. Sorry, I missed the beginning of the discussion. Thank you so much for coming here. Fingerprinting, MRI fingerprinting. My understanding is that you want to create a multi, sequence information, then go to the dictionary and match up and come up. How much AI is involved in now, creating those images instead of an analytical approach?
Yeah. So the initial work required no AI. Right. We were creating a dictionary, and actually it was just you take your signal time course in each pixel, and you cross correlate against the dictionary, and your highest coefficient wins. That's how we did it initially. There are approaches there's dictionary compression approaches. There are approaches to using AI to do the match. We're playing a lot with AI for sort of some of the iterative recons that we're doing now for fingerprinting. So AI can fit into that approach at many different locations. For some of the work, as your number of variables becomes very high, your dictionary becomes massive. And so that really becomes an area which could benefit a lot from AI. So these are all things that we're playing with, and different people in our group are trying something. So
Thanks.
Thank you. Wonderful talk. Personalized tissue contrast is a huge concept that has applications in every imaging system that we do. So if you think about like that T1, T2, ADC, to establish that personalized contrast, you're basically looking at a 3D surface and optimizing which one fits for that patient, right? So that's a really great place for AI to pick out the best of those many, many curves to dial in that lesion detection. And this kind of a parallel question is like, are using an AI tools to dial in that personalized contrast?
Yeah, so you're absolutely right. And I think that to really get to that question properly, we need a large data set for whatever question you're trying to answer. So, the fingerprinting data sets for the transition zone and peripheral zone studies that you saw were about 75 patients each, right? And so 150 total patients in each of those experiments. And that's not, in my opinion, quite enough. Like, I would love to get to bigger data sets. So, it's my hope that when we get to a multi-site validation, we'd have a large enough data set where we can start playing with exactly the question that you're talking about. I do agree that this should be an optimization question. And maybe at the end, it suggests an acquisition that you can just do on the scanner instead of doing all of these other things. So that's down the road. And I do agree. I think that it is definitely opens up that question.
Is there a formalized system for like rad path correlation such that you track all your biopsy results and potentially give concordance or discordance? Yeah,
so I would freely say that one of the weaknesses of the papers that I showed you is that we are correlating a path sample obtained from a lesion identified on, traditional imaging, and then you're correlating that the T1, T2 mapping. Because the patient went for clinical biopsy, because I don't feel like I can justify subjecting a patient to an invasive procedure on the basis of fingerprinting yet until it is well down the pathway of clinical approval. Right. So that's a weakness. There was a subset of patients where we did rad path correlation against whole mount histology, and that was published probably 3-4 years ago. But the tricky part there was a really practical research question. So I have to have a fellow or somebody from my group, a clinical fellow, someone who knows enough radiology to go to the pathologist, sit down with a pathologist, and circle on the pathology map where the radiology is showing the abnormality. And then those images have to be fused, which the computer scientists do, or a BME person, and then they write a paper. They do all the correlations. They do the radiomics and they write a paper. The labor is 100% on my clinical fellow. The credit, she's somewhere in the second, third, fourth author position, and the credit is going to the computer science student who's running all the radiomics, which is not wrong, but it's not also right for my fellow, right? And so it just became I just could not I wanted to know the answer to this, but I could not justify that much of her time where she was not going to be able to write the papers that were going to push her career forward. And so it's a really practical thing. And for that reason, I pulled the plug on it at some point. It just was not fair to her, right? And so I need a better way of doing this. And maybe, in the brain, we did some of the radiomics ourselves, but even there, like, that's not fair to the person doing all the programming and doing. So there wasn't a good way to figure this out. We can have co-first authors, I guess, like, that kind of approach. But we needed to be able to credit the appropriate people appropriately to do this. But I think eventually the answer to your question lies in taking whole mount pathology, correlating it against our imaging, and coming up with answers based on that. And the whole mount pathology is getting a lot easier now that it's becoming digital. Back in the day when we were doing it, it was not digital. That was another complication. We had to digitize it, then do all this.
So, great question. I think, pathology is more of the standard, but regular HME thing it's a cancer, but it's not aggressive versus aggressive cancer. So, in the top of those H&E things, just like X-ray for radiologists, right? For pathologists, I think we have a little more molecular, for immunohistochemistry, those kind of things. We need to really look at the advanced imaging with advanced pathology, not regular imaging with H&E thing. So how do we move that direction?
I think that, so you're absolutely right. And I think that again, having digitized versions of all of their pathology data, so Michigan's moving towards that now. Like, so we've gone to digital pathology, and their data sets make ours look tiny. And so, but they're moving to digital pathology. I think it's taught to get better, the ability to do this in the future. But still, identifying the lesion that is of suspicion is important. And we also have, we have our own biases, right? Like the satisfaction of search and things like that. And so there are problems with this. I'm reminded of a story that Rich Barron told me. Rich Barron was the chair at University of Chicago when I graduated from my residency and fellowship. I was looking at UFC as a potential job for a director of MR. And he told me he was a pioneer in liver CT. And in the early CT days, they were calling liver lesions, and it would go to liver cutting either in an explant or in autopsy. and the liver cutting, they would not find the lesions that he was calling. And he was like, it looked like a light bulb to me. Why, where is this lesion that you are not finding? So he went to liver cutting and he found out that they would take the liver, they would take a bread knife and they would cut it in 4 slices. And he would look at these 4 slices on both sides. And if they didn't find the lesion, that was read as negative. And so Rich then said to them, no, wait, cut here. And he told them where to cut. And lo and behold, they started finding those lesions, right? And so that's how early liver CT, at least that's the oral history that I've been told by Rich. That's how it came to be. So pathology, I think, is an emperor, but sometimes it has no clothes, and we have to be careful when we use it, how we use it. I think for prostate, for example, like even when we biopsy it, they're not looking at the entire lesion. They're looking at pieces of those fragments that we're sending them. And so could they be under calling some of the areas of aggression, or could they be missing some of, I think it's possible. This is something that will require a lot of work into the future, but that just means all of you have plenty to do.
I'm wondering a little bit about quality assurance in the fingerprinting process, because if you think about what the raw image looks like, and take the standpoint that MR is always SNR and artifact limited. How do you go from an image that's really not interpretable to know the quality of the fingerprinting that comes out is correct?
Yeah. So I didn't get into the detail of this, but what you're doing, for example, in most of the fingerprinting I showed you, you're undersampling by about a factor of 48 per image. So that means that you would need 48 of those spirals rotated around to fully sample the image. But what we do is that we're rotating the spiral slightly in K-space in such a way that you reach the full coverage multiple times. You get to look at it. And we're kind of, I wouldn't say uncoupling, but we're not exactly spatially mapping and getting each image complete at the same time, right? It's extending that experiment out so that the spatial information is there in the maps. It's not there in any individual image that's like structural information. It's not there in every individual image there. But it is giving you that information through that time course. How do we ensure that it's right? We do phantom experiments. We do repeatability, reproducibility. We do that in humans as well. And without that work, I think quantitative imaging is very poor. And I have seen papers that have replicated our work. They have not cited our work, but the experiment is exactly the same, but using different ways of mapping. And they have not published their quantitative data on phantoms and on humans. I have words for those papers. They're not very good words. And I think that does a really big disservice to the field. Because if you're not doing your reproducibility experiments, repeatability experiments, phantom experiments, then how the heck do we know if that number is meaningful? And so some of it, so the cardiac field is much ahead of some other fields. At least in cardiology, people have said that each site needs to have data that set up its mapping experiment. And that has been the kind of guidance that has been provided to cardiac MR researchers or physicians. That doesn't necessarily exist in prostate or brain or other things. And I think that in that respect, cardiac MR is leading the way in establishing some guidelines. I think they need to be there. I think that it's pollution of the field when people don't do that work a priori and publish their paper straight to, radiology or whatever.
Any other question? Okay, that was a lot to cover.
Yeah.
It's really fantastic. Thank you so much. So
We're gonna go to the second floor, so I'm gonna show something over there.